most of our waking moments thinking about how to push the boundaries of radiotherapy to give our current and future patients better care. Yet it probably has occurred to each of us, how can our expertise be relevant, make a difference, where the problem is not measured in millimeters, but in thousands of individuals, where there is lack of capacity and human resources to make a difference in many parts of the world. While contributing to global capacity building is part of what we want to do, knowing how to go about it is a major challenge. So when we heard about the opportunity between University of Toronto and Ethiopia, Addis Ababa University, we were quite excited, but also a little scared as to whether we can come put together and make a contribution. After some discussion, we actually got a champion in Jackie who took on the charge and went to Ethiopia and did the initial exploration and provided us with a very comprehensive first thought as to how we might want to approach any collaboration. The collaboration between University of Toronto and Addis Ababa University has a long track record. And Claire tells a very compelling story that makes us very excited. So we want to take this opportunity to bring what the team have learned to the radiation medicine program to give us some idea as to how we might want to move forward. So I'll first introduce Dr. Brian Hodges, and he's going to kickstart the talk. He's, of course, the Vice President of Education for University of Health Network, and also the Richard and Elizabeth Curie Chair in Health Professions Education at the Wilson Center for Research and Education. And Jacqueline Spayne doesn't need any introduction. She's one of ours, radiation oncologist at Odette Cancer Center. And they will also introduce our next speaker as well. So how to teach how to fish, right?
Thank you, Rebecca. It's a pleasure to be back in this room. It's been a few years. So it's been a very interesting summer, certainly involved in something that's very different from our usual day-to-day. So I hope many of you will also become interested in getting involved, and I hope we'll have time at the end of our talks to invite comment and from all of you. So my objectives are up here to describe the existing collaboration, as Rebecca mentioned, between the University of Toronto and Addis Ababa University, and to outline a proposal. The important word in this paragraph is a multi-professional collaboration to support training in radiation medicine. We have no conflicts of interest. At this point, I'm going to hand over to Brian.
Thank you very much. I'll be very brief. I think my role is maybe just to ask the highest level question is, why would we want to do this? And great credit to Jacqueline and the team for what will be a compelling argument, I think. But at the highest level, we have to ask, when we get up in the morning, what do we go to work for? What are we trying to achieve? And I think most of us belong to at least one and probably two organizations. Certainly, we work in a clinical practice setting, and we're trying to understand how we can improve the quality of care and the quality of the healthcare system. And while it might sound paradoxical, the Canadian healthcare system is not the best healthcare system in the world, and as we think about how to improve it, we learn a great deal from interacting with others in other places. Now, you might have a prejudiced view of this and think, yes, but how could Ethiopia's healthcare system help us? Well, many years ago, I helped set up the Northern Outreach Program in Ontario. And you would probably know there are no specialists almost anywhere in Northern Ontario. And one of the best analogies for us to understand how to work in the parts of our country that are highly underserved is to look at the brilliant things that have been invented in places where there are low resources, where there are low income. So that's one answer. The second is that many of us are teachers. And the University of Toronto's president, in his recent address, said that one of the most important things we can do with our students is help them become global citizens. And my sense is it's difficult to become a proper global citizen if we don't engage globally in some fashion. So this program is also about doing that. The TAC program is 13 years old. This fall we'll be celebrating Canada's 50th years of engagement between Ethiopia and Canada, so it's a long history, but TAC itself celebrates 13 years this year. And it's a project that started in the Department of Psychiatry and now has expanded to 22 different departments and programs. I think Ethiopian Airlines flies direct now because there's more than 100 trips a day going from Toronto through the TAC program. You'll be aware, I imagine, if you work in any international activities, that they only happen because of inspirational leadership. And we're very lucky that you've invited the two inspirational leaders who have made this program possible, the co-chairs of TAC, Dr. Clare Pain, whose poster you probably walk under when you go on the campus of the University of Toronto, who I think should be knighted soon, but has actually certainly been given an honorary degree from the University of Addis Ababa, has been leading this initiative for well more than 13 years and is the engine behind it. But this is always done in partnership. It's always two-sided, strong bilateral collaboration. And Dr. Dawit, who's a good friend of ours and colleague here in Toronto as a visiting professor, helps us to understand really how to navigate the challenges of an important international partnership. And it's really my pleasure to welcome him to tell you something about the history of the collaboration.
Thank you, Brian, for those kind words. I'm glad to be here. Thank you for having me. Good morning. How do I move this? I come from a low resource setting.
Oops, sorry. There, that's it. And then just press the forward button.
So I'm going to talk about Ethiopia briefly. For those of you who don't know where Ethiopia is one of the ancient civilizations in the world. It's situated in the Eastern Africa region, just around the Horn of Africa. The capital is Addis. It's one of the second largest country in Africa in terms of its population, 97 million now. And it also remains to be one of the poorest countries in the world, despite documenting really good progress rate in the last few decades. But it is still a very poor country. It has one of really the worst health indicators. Two are mentioned here. You can see the comparison with Canada, so that it gives you some perspective. Infant mortality rate 43, and life expectancy as per 64. Maternal mortality, which is usually probably gives another good indication for comparison, is over 400 now per 100,000 live births. That's going down from 800 in 10 years, but still a very, very large number. And you can imagine what happens with the loss of a mother, right? For any reason, when a mother dies, a family dies. And so these are the kind of really health statistics we have. In terms of infrastructure, there is now some kind of an infrastructure boom in Ethiopia. And, a good example is the recent modern public transit light rail in the city, and then there is some improvement in terms of infrastructure. But again, we sometimes say we see lots of change in Ethiopia, but Ethiopia is competing with itself, or it's like it's measuring against itself 10 years ago. So there are really good improvement in infrastructure, but there is a lot to be done. However, I just would like to say that, of course, we measure things by the way you measure things depends on the measurement, and then when you talk about these things, it gives you a very negative impression of what is measured. But if we change the measure, like in terms of social capital, culture, spirituality, history, It is really one of probably the most fascinating places in the world, in my opinion. Of course, I am biased. Its own language, its own alphabet. Only 2 countries in Africa have their own alphabet, the Coptic and the Amharic alphabets. Its own calendar. If you come to Ethiopia, you will be granted to be 7 years younger because we use a Julian calendar. So there are like measures really in terms of social measures which could attract anyone. The healthcare system, it's a tiered system. We have a primary healthcare, primary level healthcare, which includes a health center, a primary hospital, and cares about like 100,000 people, and then the general hospitals, and then specialized hospitals. When you look at the number of doctors, Ethiopia has now around 3,500 doctors for 97 million people. There is a plan and already a process in place to really boost that up and increase the number of doctors to 12,000 by 2070. We'll see if we will meet that level. So medical schools, we used to have only 3 medical schools. Now we have 31 in the last 10 years. As of this year, we'll have 2,500 graduates annually. The medical training is a 6 years post-secondary program. It's direct from high school. And now we have 12 schools where we adopted a different curriculum with first degrees. And then everyone is required to do a 2 to 4 years return of service in primary and secondary care facilities. Postgraduate specialty training started in the 1980s with internal medicine in Ethiopia, but the output remained really very low, and the number of specialties was limited. As a result of that, people were being sent abroad for training, and as you would imagine, most people never really returned, and that resulted at one point in having more Ethiopian doctors in the United States than in Ethiopia. This is a fact. It was like this probably 6-7 years ago. Only with the increased number of graduates that balance is tipped. But in terms of really having a robust and strong healthcare system, you want to have people living through it for years and years, building it up. So if every time you train and people go, then you'll have new fresh graduates in the system, which probably really halts its development. So the TAC comes in here, the Toronto Addis Ababa Academic Collaboration comes in here, as Brian said, 13 years with amazing results. Jackie will talk about this, and it's not only in medicine, but all other areas. And Addis Ababa University is the first university, one of the first universities in Africa, actually, established in the 1950s. 50,000 students and a number of programs, over 280 programs now at Addis Ababa University. At our college, the College of Health Sciences, we have 4 schools and a hospital. We have the School of Medicine with all its programs, specialty, subspecialty, master's PhD programs, School of Pharmacy, School of Allied Health Sciences, that includes nursing and laboratory technology, and School of Public Health. Are the 4 schools, including the hospital, that's the main central referral hospital. It forms a College of Health Sciences. It has nearly between 8,000 to 10,000 students and over 82 graduate programs, of which a significant number, around 18, have some partnership with Toronto, which we are proud of. I'm a graduate of that program, one of the early graduates of the program in the Toronto partnership, and I've been directing the graduate programs. And I had a very hands-on experience of how the partnership works and how valuable it is in terms of really producing the necessary graduates. I'll just conclude by trying to answer just one question, the question which Brian answered, and probably I will just put another twist in that. Why do we do this? Why do we really partner? And I think I like to give this statistics all the time. So Ethiopia, 97 million people, so 55 million are in the school age. Of the 55 million people are the school age, which are young adolescents and adults, only 22 million have some access for education, some kind of education. It could be a grade 1 education. And then only 2 million actually finish high school. We are talking about 97 million. And then to date, the number of university graduates in Ethiopia remain to be under 500,000. So we all are here in medicine because we want to see some change in the world, and we want to change the world. And what better way there is to change the world other than education? And to do that, it's good to partner where you can really bring a significant impact. Thank you very much. Sorry, I talked a lot.
Thank you, Dawit. I'm going to change gears a little bit now and talk about the cancer, specifically about cancer, and the cancer burden in low and middle income countries. We have heard Ethiopia falls in the low income country bracket, and I'll come back and talk about statistics in Ethiopia in a few minutes. But let's just think about the cancer burden. We know in our everyday lives that demographic changes mean that the number of cancer cases in our world grows and will continue to grow. We also know that because we have made advances in earlier detection and advances in how we treat cancer, that outcomes in our world have been improving, and with the bright minds in this room will continue to improve. But if you turn and look at low and middle income countries, and there are just some quotes here from various international organizations I happen to pull off the web, they're random, there are many, many others. The demographic changes multiply many, many fold in low and middle income countries. And what's more, because of late presentation and a whole host of barriers, including the fact that most of those cancers present late, the outcomes are dire. As a consequence of that, the majority of cancer deaths in the world happen and will continue to happen, and even more so in low-income countries and, to a certain extent, middle-income countries. So if there's anything we can do to save lives from cancer, this is an opportunity for us. I think everybody is sort of at least peripherally aware that the world has been talking about this. We're not talking in a wilderness here. There has been a lot of attention on development goals. The UN tends to set broad-scale development goals, and many people may be aware that the Millennium Development Goals, which were set 15 to 20 years ago with a target date of this year, included things like child mortality, maternal mortality, proportion of the population living in poverty. And not because the goals happened to have been set, but because changes were happening in the world. Many of these were met, and many of them were met early. So we are advancing and thinking about development and improving development in lower and middle income countries can have an effect. So the Millennium Development Goals have translated into the Sustainable Development Goals, and these are goals aiming over the next 15 years. And there are actually 18 realms, and each of these have multiple targets. I'm going to focus on number 3, which is the target, the health target. And within that health target, there is one that says by 2030, we want to reduce by 1/3 premature mortality from non-communicable diseases through prevention and treatment, and also to promote mental health and well-being. So cancer falls into this. It falls into the NCD category, the non-communicable disease, and this is where the global non-governmental organizations are focusing on targeting improvements in cancer control. There are many organizations that are trying to contribute to this. One example, the World Health Organization publishes all sorts of guidance to try and help low and middle income countries. Another UN organization, which many of us will be aware of, is the International Atomic Energy Agency, which has a program for action for cancer therapy, PACT, and PACT runs a number of programs, including what they call the Impact Review, which is like an assessment they do for low-income countries to give advice on how to set a cancer control plan. They do some training programs, and they also have this group that advises on radiotherapy technology. The resources of PACT are actually quite limited, and they can advise, but there's a limitation on how much implementation they can do. They do publish various scholarly articles. This just happens to be one looking at radiotherapy resources in Africa. This was published a couple of years ago, and this shows where the radiation machines are in Africa. You can see that they tend to be clustered in the north and the south with great big gaps in the middle. You will see that Ethiopia has one little red dot there. But what really comes out from this is, other than possibly regions of South Africa, nowhere in Africa has adequate facilities, and most have none. And what this particular paper emphasizes is that there are many barriers to access, but one of them is the scarcity of trained professionals, and so it has been and is today. So as a result of these concerns, not only are these large non-governmental organizations pitching in, but the cancer community, the global cancer community as well, has dedicated quite a lot of energy and effort into looking at how can we help, what can be done, what needs to be done, what's the extent of the gap. And in 2009, the Global Task Force on Expanded Access to Cancer Care and Control in Developing Countries, bit of a mouthful, was formed with leaders from all over the developed world, and also representation from the third world. And you'll certainly recognize at least one name from the banner up there, and we have been part of this leadership. Our department certainly has. This task force has published two very detailed, grainy reports that have included analyses on gaps and have included many interesting case examples of how people have tackled these gaps. The interesting thing, this is a quote directly from this publication. This is a book. This is a big fat book. It's with lots of useful information in it. But it's defining the mandate of this task force to design, promote, and evaluate strategies for expanding cancer control. Interestingly, when the task force was launched, the word implementation was included in the mandate. It no longer is, and probably for good reasons, and we'll come to that. Under Dr. Gospodarevich's brilliant leadership, the UICC, the Union Internationale contre le Cancre, which is, Mary was president, I think, two years ago, 2014. And it's the voice for the global cancer community. Under Mary's leadership, the Task Force on Radiotherapy for Cancer Control was formed, focusing primarily on the needs of low and middle income countries. And calls were, again, our department was very involved in the leadership of this organization, and you can see that they published on what the intention was and set themselves a task to estimate in real concrete terms what was needed to close the gap between what exists at present in the world and what was needed to achieve reasonable access to radiotherapy in low and middle income countries in the next 20 years. Now, it isn't my role to expound on what they found, but their report in a short 1 year was presented just 10 days ago at the European Cancer Congress, and simultaneously the full report came out in The Lancet. This again is a detailed, gritty report that not only estimates the gap and what is needed to close the gap, but also estimates what the benefit from closing this gap is, and concludes quite clearly that the benefits hugely outweigh the costs. The publication also lists a number of calls to action to close this gap, and I'm going to focus, because that's what today's discussion is about, on number 3, which is how to close the gap for human resources for radiotherapy. And I'm only going to focus on the line that says that we call for new approaches to train radiotherapy professionals globally. I'm hoping to convince you that we're proposing a way to look at this. A number of other organizations have popped up to encourage people to get involved in this. I don't know if Danielle is in the room. She's one of our residents. This is an advocacy group for young professionals wanting to create leadership with an interest in access to radiation therapy globally. There are obviously also local organizations. This is an African, organization in Africa that brings together African nations looking again at the same issues. I'm going to move now to talking about some statistics about cancer and focusing more on Ethiopia. To remind you, Ethiopia is that big country in the Horn of Africa. We've seen these maps many times before. They're from the Globocan statistics from the World Health Organization, and this map shows estimated cancer incidence in men worldwide, and the darker it is, the worse it is. So you'd think, looking at that, oh, Ethiopia's not doing so badly. This is probably a little bit misleading, which I hope we'll come to understand. Not that I'm saying the numbers are wrong, but the scale of the problem is certainly not small. Again, cancer mortality in men, and again you will see Ethiopia, and these are age standardized rates, so again, doesn't look so bad. In women, the age standardized incidence rate is probably somewhere in the middle of the pack. The age standardized mortality rate is amongst the worst in women. This just adds some numbers. These aren't rates, these are actual these are numbers of cases, estimated, I would emphasize. And given that most low-income countries don't really have good cancer registries, these are no more than estimates. You'd have to suspect there's probably a level of underreporting in this. So if anything, it could be worse, but these are the best data we have, again, from the Globocan database. And there are two things that come out of this very strongly. And I've put Canada's statistics at the bottom just for comparison's sake. The first thing that pops out of these statistics is that the female to male rate is dramatically higher, and that it's predominantly a disease in the population in their productive years of life in Ethiopia, compared to Canada, where the female to male rate is a lot closer. And as we know, the median age for cancer incidence in Canada is somewhere around 60. The deaths, again, this is much what you'd expect. The incidence rates translate into deaths, particularly in women in the productive years of life. And as Dawit said, that means the loss of a lot of mothers, and particularly in low-income countries, that has huge societal impacts. And the problem is even worse than that, because, as Dawit mentioned, Dawit mentioned that around half of Ethiopia's population is school age. In this bracket here. These are population pyramids. Ethiopia has more of a population spire, where the bulk of the population is young. Compared to Canada's population pagoda, we just in the last couple of weeks passed the line where we have more people aged over 65 than we have under 15. It's very different in the developing world. So what that means is that as the population ages, these are both Ethiopia, and this is a forecast for some decades down the road, still the bulk of the population are young relative to us, because they've got several decades to catch up. So the result of that is that if you predict forwards, the burden of cancer and the burden of cancer incidence and cancer deaths remains very high in people in the productive years of life for many decades to come. I've just put up here the sites of cancer incidence by prevalence for the different cancer sites. These are estimates from 2012. Again, this granularity suggests some reliability in the numbers, which I wouldn't necessarily believe. But what it clearly shows is that it's cancers in women that are the most prevalent. So the first question is, okay, so let's look at these low and middle income countries and what's happening there. They're very well aware of the issue, very well aware. There are all these external agencies that have been supporting, advising, helping with cancer control plans. But what has also been shown quite clearly is none of these external agencies can do anything without the commitment of the national government itself. It has to come from within to have any lasting benefit. So the Ministry of Health in Ethiopia has been cognizant of this and has been participating in these international discussions. I'm just putting this up as an example. This is the First Lady of Ethiopia. She's standing next to the Director General of the IAEA and the President of the UICC for this year at celebrations of World Cancer Day in February. So they are involved, they're listening, and they're trying to find ways forward. So what has been done, the Ministry of Health has lent on Dawit and his colleagues at the Addis Ababa University and said, okay, we need to do many things, but one of the things we need to do is to expand our workforce to deal with this issue. So Addis, AAU, I came to TAC and Brian went to Fifi, and Fifi and Rebecca came to me, and I flew to Ethiopia. And that arrow should actually be over to here. I did not have any interaction with the Ministry of Health. I spoke to people at the university. And equally, this arrow should come from the university. I produced a report, and it's been discussed at the department's, the UTDRO Executive Committee. At this point, I have cautious support, and here I am talking to you, and I will be doing the same presentation up at Sunnybrook. So what are we, I want to get to what we're proposing. First of all, I'm going to describe what are the cancer care facilities in Ethiopia today. Ethiopia has one department of clinical oncology. It's at the Black Lion or Tikar Ambessa Hospital, which is the University Hospital in Addis Ababa. This is a picture I took from an article in The Lancet. I could not have taken this picture because every time I went there, this frame would have included probably at least 200 people up this corridor, up here, on this overgrown piece of land, on the road, waiting to be seen, waiting for treatment, waiting for relatives. It takes your breath away. We think our waiting rooms are full. You ain't seen nothing. This department opened in 1998. I understand they see about 5,000 new patients in the outpatient clinic a year. Remember, I told you that the incidence of cancer is estimated currently in Ethiopia at least 60,000 new incident cases a year, so a small fraction gets seen by an oncologist. The department runs an inpatient ward. They have a chemotherapy suite. The wait time for treatment, and that is from consult to treatment, is 6 months. There is a separate hematology department, which also has a ward, and there is a pediatric oncology ward with 26 beds that treats children under 13, because that's as big as the beds can accommodate, and it's mainly with hematological malignancies. The radiation therapy facilities. There are 2 Canadian cobalt units. One of them is 11 years old. It still has its original source. The second one is 6 years old, also with its original source, but certainly when I was there, it was out of service, waiting for parts. Kind of wonder why you don't put this source in this machine, but anyway. They plan on paper with 2D simulation and fluoroscopy. Despite all of these limitations, they run a long day and treat 70 patients per day, 5 days per week. The wait time from consult to treat is estimated at 4 months. So you can imagine a lot of those consults don't get to treatment. They have recently added an HDR brachy machine using a cobalt-60 source with remote afterloading, mainly used to treat cervix cancer. So that's, the staffing of this department. There are 3 clinical oncologists trained in the Northern European model. They were trained partly in South Africa, partly in India, partly in Scandinavia. So they look after both systemic therapy and also radiation therapy. There are 2 medical physicists trained in South Africa, 3 radiation therapists also trained in South Africa, and 3 nurses with some oncology training overseas, short terms overseas, and 14 other nurses that run the inpatient wards and the outpatient clinics. Training. What training do they have there currently? A clinical oncology residency program, so the doctor part of it, was initiated and is in place. So Dawit described how after secondary school, the best students are selected to go to medical school, where they spend 6 years. They then spend up to 4 years, often in very remote communities, delivering primary and secondary care. And then they're selected to do, if they don't burn out, which I can't imagine, they're selected to for postgraduate training. So the young people that come into this they're actually extremely well trained when they come in to this program, and very, very committed. The teaching is all done in English, and it's done on a model very similar to the TAC model, with collaboration at the moment from the University of Oslo, which also runs a clinical oncology program. They have 4 to 6 residents per year. There's a 4-year duration, and the residents spend a few months in Oslo in their last year of training, and they're hoping to graduate their first cohort next year. I didn't meet the residents when I was there. Of note, there is also a hematology department, and the training for the hematology residents is very similar to our own hematology training here, and was set up with the help of TAC, that helped set up not only the hematology fellowship, but also the internal medicine residency training, and that's well underway. And I, in fact, had a hematology fellow in my lymphoma clinic just last week, was over here for a few months. So what is planned from here? So the IAEA did do an impact assessment for Ethiopia a few years ago, and helped, along with other agencies, helped formulate a cancer control plan. There is a plan in place for the installation of 6 LINACs. The timeline at the moment is not concrete, partly because of a staff issue, which we're going to come to. The plan is to install 1 bunker in Addis. That will probably be the first one installed. It could be as early as next year. The bunker apparently is ready. And then the plan is to install 1 LINAC in each of 5 university hospitals in 5 provincial cities. The installation and commissioning will all be done with support from IAEA, as well as a little bit of training. The plan is also with each of these to install CT simulation with appropriate computerized planning systems. But none of this can happen. None of it can happen without trained staff. So AAU has been tasked with developing training programs. Problem is, AAU has very limited capacity of people who can do this training. I won't review the literature here about the different models for supporting training in this kind of setting. Dawit mentioned the model where you send your people overseas. It works in middle-income countries, and certainly U of T and our department has been doing quite a lot of that, where there are jobs for people to go back to doing what they're trained to do. Problem is, in low-income countries, there's a 90% attrition rate, and even if people go back, they can't practice in the way they were taught. Another model is the observership model, where people are sent overseas just for short periods of time. The trouble with that is it does work to gain specific skills, but the problem we have is that it's a dribble, or maybe a trickle into the bucket, and it doesn't achieve sufficient critical mass so that you can build from there into your own sustainable programs. Hence the approach to TAC and the approach to our department. So what we have been asked to look at is to support training programs in, at the moment, 3 areas: radiation therapists, medical physicists, and oncology nurses. And we have representatives of the nursing department. Amy's here, and I don't know if anyone else from nursing is here, who I hope will be working with us. We will also be needing clinical oncology nurses to participate in this. The plan is for in each of these areas to start a 2-year master's program after a relevant bachelor's. So in the radiation therapy, there is the aim is to take students who've graduated from the radiological technology, which is the program that currently produces the staff that man the radiology facilities in Ethiopia. So Addis Ababa has one CT scan, one MRI scan, and obviously plain film. Most of Ethiopia mainly relies on plain film, but that's staffed by graduates from this program, and clearly there is some background here that will be relevant for radiation therapy training. Medical physicists, what they're aiming to do is take people from the physics program, and nurses, there is also an undergraduate program in nursing. And interestingly, our Faculty of Nursing here in Toronto has already been involved for some years with TAC, and some master's programs have already been established in, for example, pediatric nursing, I think, and a couple of others. So they have some experience which could be helpful for us too. The good thing for our department is the first two, the medical physics and radiation therapy, fall within our department. So we have the opportunity to work here closely together. The plan at the moment is not to focus on radiation oncology physician training. That may come, but that's not the priority right now. For each of these, the model that we're proposing is very much based on the TAC model. It has 3 phases. The initial phase is support for curriculum planning. I'd like to emphasize here, we're not suggesting that we take the U of T program and deliver it in Addis. We have to be more pragmatic than that. The AAU is coming up with a curriculum. They need input from us, and they need our resource to deliver it. That's what we're focusing on here. But we need, in the initial phase, to be involved in the curriculum review and planning. The big chunk of human resource is needed in the second phase, and I would say this is ongoing right now, or will be as soon as I can get some help. The second phase is I hope kicking off next year, early in the year, I hope. And that's the provision of human resource for teaching visits. What we're hoping to do, and this depends on what we can put together, we're hoping to send up to 3 visits a year, each visit for a month. This is quite a high ask. And for each team. What I'm hoping we can do is collaborate between our different groups within our department to send 2 faculty, I hope, from each of the fields to deliver both didactic and clinical skills teaching. And to do that teaching and collaborative that teaching, there's much that we can teach across disciplines. And also we are being asked, and this is not immediate, but during this program to consider supporting a small research component in the master's program. A lot of that can probably be done remotely, but that will need even more resource. And the long-term aim, and this is 5 to 10 years possibly, I'm guessing, is to achieve sustainability, so that what we do is through this process, we train the faculty there so that they can deliver the program, and then our involvement becomes faculty development and continuing education, and continuing, I hope, to have some input into helping develop treatment protocols and things like that as they begin to catch up with the sort of treatments that we can do here. So I've put up a timeline here. It'll go as fast as we can make it go. We're currently putting together a memorandum of understanding, which will be a formal document between UTDRO and the Department of Clinical Oncology at Addis Ababa University. which will specify exactly what we are going to deliver and the limitations to that, and also what supports they are going to give to us. As I mentioned, the curriculum review is ongoing. This is my recruitment effort, and it will be ongoing. And we will be, for those who are interested, we will be having planning meetings and very important team briefings to know what to expect, and hoping to send the first pilot team in the new year, I hope. So we need people for the initial phase curriculum review. That's very much based here. We need people to consider teaching visits, so talk amongst yourselves. Contact us. I'm not asking for anything like a commitment at the moment. I'm asking for interest. And think about whether, if that isn't what you're interested in, whether you might be able to support some small research projects. I'll put up the contacts at the end so that people can note them. I'm going to just take a deep breath and talk about, as openly as I can, what I think the barriers to this are. There's a lot of uncertainty. There's uncertainty about exactly what we're going to deliver, when we're going to deliver it, whether it'll be successful. There's uncertainty. We know that. We have to be comfortable living with the uncertainty. There's uncertainty, if anybody's going to ask me, is there political risk? Is there personal risk? Ethiopia is a stable country, but it's in a part of the world that's very unstable. So I can understand people having some concern for that. There are restricted facilities. Dawit, on one of Dawit's slides, there's a comment that internet use is limited. So as an example, we cannot do remote teaching by teleconference. We just can't. There aren't facilities to do that. We have to be there. Eventually, I hope we will be able to, but we can't right now. The facilities, when you get there, are restricted. The places you'll stay are not luxurious. So there are, you need to be comfortable with that. I'm worried, are we going to get enough people to support this? Because we need quite a few to make it work. Funding is an issue. Ethiopia is a poor country. They do not have a lot of money to throw at this. They will pay for airfares and accommodation for teaching faculty who are prepared to stay for a month. That's why there's a month requirement for the teaching stays. The department feels strongly that if we support this, this has to be viewed very much as a professional activity, part of our academic activities. It is not a volunteer activity that you do in your holiday. This is an organized professional activity. Problem with that is it means that what we need to do is release people from their day jobs to go on paid time. That sounds great, but I don't think we can expect the Ontario taxpayer to pay for people to be sent overseas to teach. So we need to find some way to fund backfilling of these people's places. So that is a challenge, and we're looking at different ways of doing that. I don't have the answer right now, and I'd welcome any suggestions. But the opportunity, and I'm circling right back to where Brian kicked off, it's the opportunity to make a real difference if this works. And having acknowledged the risks and barriers, it's a challenge, but if it works, it'll make a real difference. And it's in the setting of a proven University of Toronto model where there is a framework and a structure, legal issues have been looked at, insurance issues have been examined. We're not starting this in a green field. We're working with a highly committed partner. The staff at AAU are deeply impressive. They work hard, they're very committed, they're well trained. They really want this to work, and they really want us to help them. They do have other people involved, as I've indicated, and they're in a hurry because they can't afford to wait. But I think the feeling is that the Toronto model has worked very well. So we'd like to make it work here if we can. If we can make this work, potentially this is a translatable model to other low-income jurisdictions. This is a new approach that I couldn't find in the literature anything that describes this, particularly in the oncology and radiation oncology arena. We have an opportunity here to lead and show how this is done. And this is within our departmental and our university mandate to try and do this. It gives us an opportunity for interprofessional collaboration in our department and also for collaboration between our different sites, which we've been trying hard to encourage. It's an opportunity to get involved in some low-income country research. It's interesting. The problems are different. And I've put at the bottom there because we can. It's easy to say, oh, there's lots of people that can do this, but think about it. You need a very big department. You need a department where the different disciplines are prepared to collaborate together and listen to each other. You need a university that supports this. There aren't many departments like ours. So I think a lot of people, and Dawit reminded me of this proverb when I was in Ethiopia. You can give a man a fish and you'll feed him for a year. Teach a man to fish and you feed him for a lifetime. We want to go a step further. We want to make sure, if we can make this work, that we help Ethiopia learn to teach to fish. And that's where we, without doubt, will save lives, lots of lives. We'll relieve suffering. And ultimately, this type of approach helps build a society. Talking of fishing, these are some beautiful children who've been fishing at a village called Langano in the Rift Valley, south of Addis. It's a beautiful country. If you go for a month, there'll be lots of interesting things to see at weekends. So I'm going to put out the contacts there, just hoping people will make a note. A lot of you know us. Kate Palmer is here. She has been involved in discussions for some time and knows what's going on and is going to be our point person for the radiation therapy training. Jean-Pierre is also here, there you go, for physics, and myself. So I'm opening the floor. Please, comments, questions, to me, to Dawit, to Brian, whoever.